Gaurav, Agarwal, co-founder TATA Maheshwari, Mr. Mayank, Banerjee, CEO and co-founder Eden Healthcare, Dr. S.P. Bhattacharya, founder and CEO Bhattacharyyas Clinical Records Research and Informatics LLP, Dr. Shashi Bhushan, Gogia, President SATHI. And to moderate this session, we would like to call upon Mr. Asim Abbas, partner, Luthra and Bhushan offices, India. Over to you, Mr.
Thank you very much. Good afternoon. Welcome you all. We have a very interesting topic today for discussion and a very distinguished panel. The topic is Stack and Blueprint, Building Digital Public Infrastructure for National Health Database. So this topic is two components. One is the digital infrastructure, and second is the huge database of 1.3 billion which resides here. Just to give a sort of a brief context before I raise a specific question to the panel members, and towards the end we'll have a Q&A session. So we have this National Health Policy of 2017, whose one basic objective is to create a digital health ecosystem. And in the last 4-5 years, there have been a lot of consultation paper which essentially are given nuts and bolts to create this federated digital architecture. And one key theme of this is the digitalization with respect to national registries and other stakeholders who are in this whole ecosystem. So in today's discussion, we'll be talking about network architecture, the standards, interoperability, something to do with data protection, and something to do with the protection of the consumers also. So just to take it forward, I think I'll start from the network architecture, and my first question will be to you, Mr. Maheshwari. Mr. Maheshwari is a I'm sorry. So Mr. Maheshwari is essentially a tech person, and my question is that this national health stack is essentially an open API based. Now, there are some principles which have been proposed which will be adopted to build this network architecture. Your generally thoughts and comments on those principles. Are these sufficient or something needs to be done? Is there any comparable example in India like a UPI-based system which we have?
Sure.
Just one, in the sense that each speaker can take around 2 minutes to respond to this, then we'll have the next round of discussion.
Sure. I think National Health Stack in itself, right, is a pretty visionary mission that the organization, the country is trying to implement, right? And I see it more than just an API. API is just a part of what the health stack is about, right? And how is it very different than UPI? Because UPI is mostly an interface between how you do transfer in real time from one bank to another, while National Health Stack talks about how do you store and share the data for the 1.3 billion population that we have. The principle that the health stack is based on, right, primarily the 5 big ones, the interoperability, scalability, security, portability and modularity, I think are very essential in itself when we talk about health stack, how the data needs to be stored, shared with the secure manner. But at the size and scale of India, if we really want to see the success of the health stack implementation, I think few more things, right, adoption amongst different stakeholders, how are we going to have the right governance structure and the right incentive structure for the adoption is going to be very, very key. Right? Because even if we compare with the systems in the developed countries like the US or the UK or any other place, that has been the key problem, right? You can have the right architecture, you can have the right interoperability standard, but if you're not able to make them adopt throughout the ecosystem, it becomes really difficult to see the success of those platforms.
So, So let's say interoperability is very key, essentially for the seamless flow of data. And one of the preconditions of interoperability is that we need to have standards and specification in place. And Dr. Bhattacharya is expert in this area. So my question to you, Dr. Bhattacharya, is that do we have sufficient electronic health record standards to ensure interoperability or seamless flow of data within this system, and more so in a scenario that when a data entry happens, there has to be a reliability and authenticity of that data to ensure that the data is safe, secure and correct?
Okay, thank you very much. The short and sweet answer to your question is yes, we do. We do have those standards already in place. The EHS standards for India were published, I don't know how many of you are aware, but in 2013 the first version and 2016 the second version. It was supposed to be updated every 2 years, but it has not happened since. But to be honest, you really don't need, because there are no new standards which have come in. But and the EHS standards covers end-to-end, including privacy, security, the whole lot. However, if you're talking only of interoperability, yes, we have got several international standards which are there, and I can name a couple of them. Not a couple of them, actually 4 or 5, to be honest. And interestingly, the national health policy which you talk about, it is, then they came up with national health blueprint, and it has undergone many avatars. But the latest document, which is from Ayushman Bharat Digital Mission, doesn't really talk about any of the standards I'm going to just tell you. And the reason is because it is not easy to implement these standards. I don't know, this is the industry says it is not easy. I know how to do it, and I found it very easy. So I do not understand why. And I am not a technical person. I'm a medical doctor. I'm a general practitioner, and I have done medical informatics for now 35 plus years. But so if I can do it, I'm sure that the technical people can do it in a jiffy. Anyway, the standards that are there are for the logical model, logical data model, the open air, open EHR, that's how you pronounce it, open air, and you have got FHIR. FHIR is message information model. So for messaging purpose, to exchange messages between systems, you have got FHIR, international standard, and for if you want to design your own data, you can use FHIR, but it is much easier if you use open air. It gives you everything, including data size, the data type, the upper, lower boundaries, and cardinality, ordinality, the lot. And FHIR also gives you all that, but FHIR is more for exchanging messages, so it is not that difficult if you use open air and you do then map to FHIR and back again. It is very simple, straightforward. I have not faced any problem till date. Now for the content, the concept model, because information model has 2 aspects. One is the logical model and another is the concept model. The concept model is the data, and that is where SNOMED is my preferred one. And it was also mentioned in the previous version of ABDHM, but it has since been subtly dropped, but with a very ominous looking sentence saying, this does not mean that it is not going to be there in the future versions. So be prepared, it is going to come. So, but the beauty is that if you use OpenAir or FHIR, you already are going to have to implement SNOMED. And then there is LOINC for laboratory results, not for orders, but for results. And of course, the good old ICD is already always there. Interestingly, yesterday I heard that 11 has already come in. I knew it was coming, but the jump from ICD 10 to ICD 11 is going to be real fun for me to watch. It's completely different architecture. Thank you very much.
Thank you. Thank you. So from standards and specification, when we are talking about the national digital health infrastructure, which will have data of billions, 1.3 billion Indians. So the next question is about the safety and security of that data. And so this question is to Mr. Agarwal, that this national database will have a data repository of billions of people. So is this network architecture has sufficient checks and balances to ensure safety and security? I believe it will be a cloud-based sort of a service. Is there any possibility of other technologies like blockchain and all that?
Yeah, thank you for the question. You know, if you think about, if you leave national health stack or national health database for an instance, and you think about data in general, then even today, billions of records for billions of people are stored online in a reasonably safe and secure fashion. Blockchain as a technology, while great, does not sort of exist in comparison at scale, which cloud exists, and there are very, very well-defined safety and security protocols, which the Indian government, for instance, is also trying to come up with a data protection, data privacy bill, etc. So I think there are many important reasons to consider a federated architecture of data. First and foremost is that if you think about health, then most of the health data is generated at the periphery or at the center where a health service is given to a patient, for instance. And when health service is given to a patient, actually it makes sense for that entity to sort of keep that data with itself for safekeeping. Of course, in co-ownership or maybe with ownership of the patient, with consent of the patient to actually keep that data with itself, rather than be in an always on, always connected model where it's constantly transferring that data back and forth to a central system. I think the second sort of thing which is very smart and which comes for free, though Dr. Bhattacharya will sort of also look at the downside of this, is that if you do a federated architecture, it pushes out your problems of actually adhering to a single standard, right? Because every local entity can sort of store data in its own way, and somehow the challenge of aggregating or standardizing that data is pushed out to the guy who's trying to aggregate or standardize this data, or bring it all to one place for the patient to see in one place. And on that there are these concepts of account aggregators, etc. But largely things have been silent. Lastly, I feel that while blockchain may be a very interesting tool and technology, and there's some great work that's been done across the world on healthcare data storing in blockchain, I just feel that for a country like ours, where we have much more fundamental problems around digital data being generated in the first place, right? One of the things that we have to accept, and I want to get back to answer Dr. Bhattacharya's question also, is that there's actually no incentive to generate digital data in this country. You cannot pass it anywhere. There's no insurance exchange. There's no, at least not today, and it's being envisioned. There's no usage of that digital data to enable any use cases which help a consumer, let's say, get quicker access to insurance, get faster enablement of its policies, etc. And as a result, what's happened is that nobody has done any standardization. And we were involved when the first NOMAD came around, and we looked at implementing it. But then eventually what we said was there's a cost to implementing a SNOMED. We don't understand what's the benefit of doing it, who's going to ingest this data, what are we going to get in return, are we going to get other people's standardized data as well? And eventually, businesses make a pro-con decision on cost versus benefit, and we dropped it. So I feel that until we solve the core incentive problem in digital health data, I don't think we are going to get to standardization or anything. And which is why I feel that the federated model is great, because it forces entities to start to digitize and push some data. It actually gives, hopefully with the account aggregator models, etc., it creates an incentive for some player to start to bring that data to one central place and show it in a way to users that actually makes it useful for them to take some action on top of them. And as a result, gives benefit to standardization, etc. as well.
Thanks a lot. So I think on this incentivization of digital data, just one observation that I think till last year, there was a discussion about non-personal data and putting a framework in place for monetization or incentivization of non-personal data. But somehow that concept got reflected in digital draft data protection bill. So that's at a, let's say, the network architecture, then standardization and safety and security of data. The next important issue is its implementation. Implementation in a country which has urban, rural, remote areas, digital literate, digital illiterate. So the implementation is essentially a big challenge. And I think to complicate it further, health is a state subject. So there would be an involvement of state governments. It cannot only be a central driven. So in that context, I come to Dr. Gogia as to how this national health stack should be implemented. Should it be participation of stakeholders on voluntary or mandatory basis? Because I think that question is still open. Should there be a cutoff date, or should it be in a staggered manner? Or is there any way there can be an improvement in the suggested approach as far as the implementation is concerned?
Thanks, and very interesting that, first of all, let me just correct things. NHS, National Health Stack, was the basis with which the ABDM was made. So we prefer to use the word ABDM now because NHS was one of the building blocks to that. And there were two parallel approaches which really brought it about. One was the NHS, which was promoted by the Ministry of Health and the Planning Commission. And they had a much more, and what Mr. Agarwal is saying is making eminent sense. There has to be a business case. And NHS had a business case, in which they worked on, and this is how the entire plan came about, was that when the PMJA was implemented initially, and they put in some IT as a method of checking and distributing the thing, and they found the frauds were just pouring in. And they said, yeah, this is how IT works. And they got it out. And in fact, I'm interested also in this because my friend's wife was in Luthra was one of the first ones to catch these frauds. And she used to tell me, and we looked at the data and we found that, every case of fracture is always compound. Every case, every case of when they're doing a LSCS, they're also doing a hysterectomy along with it. I mean, there were so many things which were, just out of the way, and they looked back at it and they could capture it. And unfortunately, what has happened, parallelly, the NDHB, the National Digital Health Blueprint, had come about, which was by the Ministry of Health, which is where the EHR standards are working. And this is what Suman Bhattacharya, being one of the architects of EHR, he is obviously in favor of it, that it should come about. And he is very right also. The NDHB was working about EHRs. The NHS, or now, the entire thing is ABDM. So that's why I'm just saying that ABDM is now the word to use for that reason. ABDM is looking at actual data which is being transferred, which is claims data. Claims data is coming in, and they are saying that we want it to rest on 4 pillars. Initially there were 3 and they added a 4th one. The 3 pillars, and which is very, very sound. One is the patient ID, which is the health ID of every this thing. Second is the facility ID. Third is the provider ID. And the 4th one was added later, was the drug registry. So these 4 working through what is called IHECM, which is Integrated Health Exchange Consent Manager. So that consent manager ensures that data is properly shared with privacy and all, which is your concern anyway. But it only talks about PHR. That data creation, which Mr. Agarwal was rightly saying, is a challenge. That data creation is only the claims data. Now we want much more data to come in to be a truly functional, to function all the things. Just claims data is not enough. That is the only problem. But I had a very detailed talk discussing this with one of the persons who's advising NDHM and all that. His name is Arindam Basu. And he was saying that we are going to get some things about SNOMED and all that also in place. So it's going to work. I think so.
No, I think, let's say, should it be voluntary, mandatory in terms of its implementation? There are multiple stakeholders. There are hospitals, clinics, insurance companies, patients, doctors. So what should be that approach? That
Thanks for that.
essentially was the
Sorry for
question.
reminding me. I got carried away. So it has to be voluntary, but what the NHS, I mean ABDM, I will not call it NHS now. What ABDM has done is that the claims data, when you want money at the end of the day, you have to give consent. So they are following that concept. It is voluntary, and the bigger problem that I face is that outside the claim data there is no data, which is what it is a problem. So sorry, we have to find a way of getting much more data inside, and I was talking with some of the delegates on a personal basis on how SATHI, our organization, is trying to do that component also.
Thank you, thank you. So coming to you, Mr. Banerjee, I think is a question relating to implementation. Incentive mechanism to implement this scheme. So what's your thought on this?
Yeah, so I think it's a very good question. And I think when I think about this in the context of UPI, which for a lot of people is the shining beacon, right? And I think there was a nice little window where it didn't matter that you couldn't make money. I think that was amazing, and adoption was great, and people, investors poured hundreds of millions of dollars into it with the notion that at some point, sure, you'll figure it out. I think that unfortunately, that moment has passed. And therefore, for the adoption of ABDHM, we have to think about, is the government thinking about it in the context of, we are going to be a payer, we're going to be a provider, or are we just going to be a regulator? I think particularly in urban areas, you can make the argument that payers and providers already exist. So the government might want to consider focusing really being the regulator, the person who sets the standards, enforces them. Maybe it's voluntary, maybe it's not. I think the thing that's really interesting though is in that role as the regulator, what can the government do to incentivize adoption, particularly around financial incentives? I think one of the things that Gaurav mentioned was everyone wants to do this. And then when you realize how complicated and nuanced it is, you think, wow, okay, it's difficult, it takes up a lot of engineering bandwidth, and actually, at the end of the day, I'm not sure how I'm going to explain it, for example, to my investors. And I think the implementation piece, the best thing that the government can do is hopefully find ways to incentivize adoption for people to build on top of the existing network. I think the thing that is really scary, at least from an adoption point, and this is a purely personal, biased, self-interested view, is if you ended up having the equivalent of zero MDR. Because I think people will still make it work, especially in urban areas. There is enough demand. You will find a way through it. And I think it will be very interesting to see if the government, as the regulator, decides we're going to encourage that, or we're actually going to say, yeah, you should do it, but good luck making money. And at some point, someone will have to solve that problem. And I hope it's soon. And I hope it's smarter people than, well, for me, for sure.
Thanks. So, so coming to standards, Dr. Bhattacharya, and this, I'm not very familiar with this area, so maybe my question may not make sense, but just I thought of generally raising this question. Some sector, let's say with telecom and IT, they have a specialized body which specifies standards. It's called TEC. Then there we have a Bureau of Indian Standards. Now health will be a huge sector in days to come if this scheme is implemented. So, and we generally rely on international standard as on today. So is that approach fine, or do we need a sort of a specialized body to evolve standards in India, or do we have a sufficient organization or infrastructure in place to do it?
BIS is already having a sectional committee which looks at health informatics standards. So, so there is no. So therefore, the point is that to answer your question, yes, we already have it. But National Health Authority, I think that was the name that these folks had coined. So this authority would be ultimately in charge of implementation, but they are not really, as I said, these standards are difficult, let me put it like that. They're not easy to understand, but if you understand it, it makes your life very simple. Now, having said that, all our standards that EHR standards for India talks about are international standards. The ones that I mentioned are all international standards. They are being used worldwide. It is very important because I work with the EHR, the electronic health record, the data that we generate, we as clinicians generate. So what happens is that you must realize that there would be people who are moving from country to country. So until and unless we have an interoperable system where data from outside can seamlessly flow inside and we are able to see it, and whatever we write or record is also visible to the others. So that process has to also be there. It's like taking your mobile phone and you making a phone call. You really don't care. All you need to know that you have a network and you're subscribed to it and it is registered. You don't really know about all the protocols that are being used and how the data is moving from one continent to another continent across the oceans and stuff like that. It's nothing to do with. But international standards are required. National standards, yeah, there have been some national standards, especially in the coding area. They tried. Arogyasri was the first one which came up with their own coding system to do. It was something like the your CPT 4, CPT 5, and also CDT 2. So they were more to do with the procedures. But I believe that that did not, I mean, obviously, because that did not fly too much. But they really spent a lot of effort and money in building that. Maintaining codes is a very big problem. It just don't build one and forget it. Just think of it, ICD 10, now ICD 11, ICD 12 is already being, the architecture is being discussed actively. So it is an ongoing process and it is very expensive. The people who work with medical codes or any code, especially medical codes, are very few in the world, and they command a very high salary. So you have to spend a humongous amount of money on them in order to get them, and they are, you can just imagine, it's a price commodity. They would leave if you don't give them the proper incentive, and they're very temperamental people. So, but as I heard that there was a lot of expense, and you felt that there is no business case for it, and therefore it didn't make any sense for you to invest, which means that you are, I mean, there would be many organizations, not TATA, 1MG, they have plenty of money, they're rolling in it. But there's others who would not have that amount of money, and they would essentially ask it for free. In fact, SNOMED is available for free in India. But there are now a number of implementations, and the benefits are tremendous, but one needs to know how to use it. So we have to use international, national standards. If you build some national standard, you must have the vision that this must go international. So you cannot just simply say, I'm going to do it only for my local work. No. If that is your approach, please don't do it. Okay?
So, yeah, please, you have a comment on this?
No, basically, just want to tell that me and Suman have been working with BS. We have been working with BS right from 2000 when they thought of health data standard. So that was just an introduction. That's all.
So I think, Ankit, this question is more a sort of a generic question, since we are talking about the health. The very important thing is data protection there. While we have a general law, data protection, which the government is discussing, they'll probably come out with the next draft after the recent consultation process. But that data protection would essentially be the general principles. Normally there are two sectors, financial and health, which requires a special treatment when it comes to data. So you generally have thought on that, in the sense that is the health data should be treated differently from a other categories of personal data which requires more protection in terms of disclosure, transfer, or sharing?
No, for sure. I think general data protection law gives you the right framework, but when it comes to sensitive data like health, right, definite more controls and standards like explicit permission, limitation of usage, how you are de-identifying data for distribution, over there limit of use over there only for the required purpose, and also like breach notification, right? Things like those are very much required when we talk about health data, right? And these are things, right, because as an innovator, like we work mostly in the US healthcare, things which have already been done, right? So it's not about reinventing the wheel, as we say, right? There are standards, like we talked about all the international standards, be it FHIR, LOINC, ICD, all have been there with these developed economies, have been working there. So and so is like HIPAA and all those kind of data protection laws out there, which can be incorporated and makes a lot of sense when we talk about sharing or storing health data. Because when you start having this data generated and in the system available, there will be a lot of third-party providers, and even for the personal usage, you will want it to be shared with life sciences organization, with pharma organization or research, right? And hence there all these next level of protection laws, like how you're de-identifying data. Are you sharing it only for a limited use, which it needs to be used for, and not for something else, is going to be very, very key. Yeah.
So thanks, Ankit. I think continuing with the data protection, but more from a technical point of view, Mr. Agarwal, this federated, so here the concept is the data will not reside at one place, but it will be at different locations essentially, and when the data will flow, it will come from there. So this federated architecture, how does this federal architecture help in the management and storage of health data?
Yeah, actually, if you dig one level deeper, what the federated architecture today mandates in the case of ABDM or NDHM, whatever you choose to call it, is that data actually stays with the end entities, and then it's almost leased for a limited window of time to these consent managers, account aggregators, etc. And the data doesn't come, but the insights can come, right? So what that does is that limited pieces of your data based on your consent come to the central repository for, let's say, storage, retrieval, insights, analytics, etc. And then after a given window of time, that lease expires, and then that data goes away. The insights may stay, but that data goes away. So there's a lot of there's a lot of concepts that are already built in around data security and making sure that all the data doesn't lie in one place to begin with. And then also, to be NDHM compliant, there's a very, very strict set of rules and regulations that someone has to go through to actually be certified as a standard data repository for NDHM, right? So I feel that the right checks and balances are in place. There's talk of certification authorities, etc., who are going to be basically looking at your infrastructure, giving you certification rules, running tests, etc. So in general, because all the data is not in one place but in multiple repository, it reduces the risk of, let's say, breaches, because not everything is getting disclosed or in one go. And secondly, because there are very strict mandates on when data flows, how long it flows for, what can you do with it, etc. I think it limits the overall risk that you have with data exposure as well.
Okay. Thanks. So now come implementation, and I think this is addressed to you, Mayank. So we have a different mix and matches in India: remote, rural, urban, tier 1, tier 2, tier 3 city. Any suggestion to make this whole digital ecosystem inclusive in nature, to include all areas, or to bridge the gap between digital literate and digital illiterate?
So yeah, really good question again, and I think this one, for full disclosure, we'd kind of discussed earlier, and I spent the whole night thinking, what can I say that sounds even semi-smart? Because it's a very, very hard problem, right? I think coming back to that kind of framework that I often think about it is payer, provider, and regulator. I think in urban settings, you can make the argument that the government is more of a regulator and should stay more of that role. I think in a more rural role, really it's trying to do all three things. So I think in some ways, the opportunity for digitization is something that is more within the government's control, because it is the provider that actually everyone uses. It is also the payer. It can force people to adhere to the incentives because they are its own people. I think the downside of that is you might argue that actually it's just very hard to make to provide the quality of the service that we all wish that you could get across the country. And so I think one approach is to say, hey, it's actually going to be easier in rural areas to force adoption because actually it's under the government's control, and they don't need to worry about people like myself who try and think through the business case of it and think, oh, this just doesn't make sense. I think the other scenario though is maybe a slightly riskier one where you say it could do that, but historically it's been quite difficult and it's not happened yet. And maybe suddenly you will click your fingers and everything changes. Or the more extreme position is maybe to think about, are there ways for the government to stay as the regulator and enforce a certain minimum standard of what we expect? Are there ways for the government to continue to be the payer and say, hey, there is a budget for this, but actually allow private providers and effectively say to private institutions, there's a pool of money here. You have to make sure that you can hit these standards in these rural areas, and those standards have to be better than what we currently provide. See if you can make it work. And I think there, a lot of history suggests that often somehow people find a way. It's a successful model right now in the UK, in the NHS, where I grew up, where actually a lot of care is delivered by private companies, but it's still free at point of use. It still hits certain better service standards than maybe the traditional government-run healthcare service does. So I think, yeah, there's the risk-averse way, which is to say, we can do it ourselves, and that's great. We control the clinics. We will force the clinics to do X, Y, Z things. The more extreme position is to say, this is really hard. Maybe we say, we focus on the bits that we are very good at, step back and allow other people to give it a go. At least when it comes to the rural, and hope someone figures it out. But I think it is very hard.
So I'll just add to what he was saying, and I don't know why this. You're from England or you're from here?
Yeah.
Huh?
Born in Agra, moved to the UK when I was 6.
So right now you're there, no?
I'm in Bangalore right now.
See, the thing is that what he's rightly said, following the NHS model, which is the actual way to work, and to some extent, when you talk about ABDM, is serving 40% of the population. And this is where the success has come in. But, I mean, in the process, they found the problems, they found that there were frauds and things like that. But that was the thing. Unfortunately, enough data is not there. It's just that we have to find ways that more data comes in, just not ensuring that I did this procedure, that's why I need the money. That's where the money was, and people are coming in for that. We need much more data to cover the 1.3 billion population. And it is not only the people. Some states have already done, like it's a state subject. Some states are going beyond ABDM. Delhi is of course the reverse. They don't even want to follow ABDM because of political issues and all that. But wherever ABDM is coming, the data is coming in, and we are going towards that, not 100%, but somewhere we may be flaunting, these are just the starting points. I feel a lot of hope that it can come out, and this is the implementation method, that's exactly what it's saying. We are following that. That's why I was asking that, how much are you working in India to understand that it is there? That's all.
So one question actually which we have not discussed and which I think is a very important topic is the protection. in case there is a deficiency of service, when someone gets cheated in this process, the beneficiary or the recipient of service, what should generally be the mechanism, or do you think the existing system which exists in terms of consumer protection and all is sufficient? This is to Dr. Gogia, please.
Okay. See, as far as the protection is concerned, right now, I have always considered that we are not US. You know, the important data, yes, there are examples of important data could possibly have been misused, like they say that if the people knew that Jinnah was suffering from tuberculosis, the partition would not have happened. You know, they would have. So, you know, that sort of high-end people and their high-end data, we are not looking at. We are looking at people and very poor people. I don't think they're bothered about privacy at all. It is overrated as far as I think. So I'll just work on that. Yes, we do need to have, and those processes are there to anonymize and things like that. But one of the reasons which has withheld, IT implementation in health is too much focus on security. We need to prone it down. Health data is not all that important. If I want treatment, I want my data to go to everybody. Tell me what to do. And I take it that way.
Yeah, sorry, Dr. Gogia triggered that vein again. I just wanted to add that while, I have a lot of respect for the system that they built in the United States, and I lived there for 13 years. Actually, that's not the system that we should build in India at all. And it's a system that digitizes, but actually sets up such hard guardrails around your own data going from one entity to another, that it actually makes the whole system useless. You talk about HIPAA, you talk about any of the other standards and regulations that they've put in, it actually makes sure that your data cannot even be shared with you. And in fact, I remember when I was moving back to India from the US, I got like 500 pages of printed health record summary from the hospital that I went to, because there was no other way in which they could give me a digital piece of that data that could be interpreted by another system. So absolutely, under no circumstances, we should try and build a system like that. And I would just echo what Dr. Gogia said here, that you look at patients today who need healthcare. They walk around with their files. They're willing to show it to anyone and actually get help available. And we need to figure out how we enable access to this data so that they don't get deprived of what a fundamental right for them is, which is fundamental right to health. But we don't need to get overly creative about making sure that nothing happens. And in general, when we design systems, we sort of design everything that prevents those systems from doing the wrong things, and in effect actually prevent them from doing anything at all. This is unfortunately the curse of security and privacy. My recommendation, my hope is that we actually let the systems do whatever, and then weed out ways in which they are being misused to actually ensure that they always work in a patient's favor rather than working against them, right? So just a passionate plea. I feel very strongly about it, so I
Although the buzzword these days is that data is new oil. Okay, so I think we have around 7-8 minutes. So probably I think we can take a couple of questions. Yeah, if you can identify your name and then address the question to. Yeah.
Hi, so this is Sachin from Care Health Insurance. I was trying to look at this discussion from, my experience in telecom and financial services, where you had initially a very complex ecosystem, but you had standards and, the stack evolved, right? But when I fundamentally look at digital health, it's a question that for Mayank and maybe Gaurav and per se, if digital health has to be based on some rails of care management and workflows and all. From a business case standpoint, isn't a digital health compliant database the first starting point? And then from there, if you have to build the ecosystem, like I see 1mg or pharmacy, like your laboratories or your doctors writing prescriptions, right? There's a way to start with creating that data And then when you look at monetization use cases, right from care management to, in the previous panel, people are talking about how health insurance, claims denial is there. But when you fundamentally see how the policy is underwritten, if you had the linkages to your data and what are the policy terms, right? So there's a way to go about building that monetization piece, right? So just interested to see, because for me, when I look at investing in...
Can you be brief in your question, please?
Yeah, sorry. Yeah, so it was just around digital health and, monetization model per se.
I think Agarwal is the best one.
No, go for it. Please.
Look, absolutely, fair question, great thoughts, but let's also be clear. Today, India does not pay for care management. It actually pays for acute care, right? Chronic conditions in India are treated like acute care, not in a care management protocol sense. And the reason it's not treated in a care management protocol sense is because there's no insurance, there's no payer for it, right? Mayank's talked about payer, provider, regulator enough number of times, and one of India's biggest problem is the fact that it doesn't have a payer, right? Dr. Gogia talked about reduction of or at least identification of claim fraud in the case of PMJ. The reason it's happened is because the government became a payer and said, I will not pay unless I get data in this format, and because it got data in this format, it started to accept everything. Another point to add is that if you look at the data we generate within 1 mg, then everything is structured. We can't run such a big company with not having data structured, right? In fact, we publish data and it's interconnected, right? So from diseases to drugs to lab parameters to symptoms and everything, and I have a team here that works on that day in and day out, but we have probably one of the best and most advanced healthcare knowledge graphs out there. The challenge is that I don't see any need to actually make it such that it interoperates with an insurance provider or a hospital provider or let's say a clinic or someone else, because there is no ecosystem of health today that exists, right? Treatment is episodic, unfortunately, and that's the best I need to do today, right? And there's no real and the reason we have built this is because we want to internally move to a care model, right? So we have structured our data that helps us move to a care model, because bringing everyone along and figuring out how they can move to a care model is actually incredibly hard, right? We just talked about how outpatient insurance doesn't really exist, right? So sorry, but
I like to it, but I think you want to talk.
Yeah, so I think when you talk about like monetization, right, I think one thing that everybody talked about is how do you incentivize the right of data creation. Talk about clinical data, right? And I know like Mr. Agarwal talked about that, how US is so crippled on their standard, but because we have been working day in, day out with the US healthcare, it's most the organizations that have made it crippled, not the system that much. But the thing about value-based care, right, where you're not just paying a provider for the service that they're providing, but also paying for the value post the service, is, and then like very accurately said, when the government became a payer, that is when it started happening. And that is what happened in the US, because 85% of the people are insured either through the Medicare or with any of the bigger payers out there, and they are the one who are incentivizing the provider that keep my population healthy and I will give you the saving that you have made me do. I think that chain once gets built, right, when you have the right payer ecosystem and you are able to share those incentives, that if a provider is giving the right care, is not charging a person, and that save to the payer, and they are able to share that saving with the provider, that is when the data creation and the value generation and thinking about start. So I think, and monetization signs happen at the next stage. Right? The first thing is how do you enable data creation? And this value-based care model, for me, I feel, is going to be the biggest propeller if we want to have that leverage. Yeah.
Yeah, I guess I will say some, probably a couple of like semi-controversial things. I think insurance companies are far better placed to force adoption than healthcare regulators. I think there's far fewer of them. They drive a huge amount of economic benefit, and I think it's the same reason again to me why UPI worked, right? You can force 40 banks to do something. You can get the insurance companies to align and say we should do this. I think the other really controversial thing is, and this is just one based on our personal experience, I think data is amazing, but at the end of the day, it's the decision making. And so we, for example, do a value-based care model for OPD and IPD. And I think the amount of times that you get data in saying, oh, this person twisted their ankle, and you have the data to say, oh, this person got an MRI. It's like, do they really need that MRI? And I think you can have all the data in the world, and you might just realize that, like Dr. Gogia said, there's a lot of fraud. And until the incentives are aligned, there will continue to be that fraud. And that data will tell you that there's lots of fraud. But I'm not sure you actually change the outcomes and shift to a value-based care model unless you have an entirely different set of incentives, which is why I guess, to me, the huge opportunity is for the private sector insurers to say and force it upon providers. But I don't know, maybe that's controversial.
I think we are running out of time, but I really want to add to what you say. Again, the NHS model. Basically, our insurance so far is a sickness care model, which is very, very inefficient. We have to promote wellness. The government has started they did do this wellness clinics and all that. Not much has happened in that. That incentive is there. And when you look at chronic diseases and all that, it is the continuity of care record which will make healthcare cheaper by promoting wellness, preventing the illness is what you have to work on. And it is definitely data will provide that, a continuity of care will provide that. And NDHM, as I said, is just a very, very basic building block with these just IDs. We have to put an EHR in place. Hopefully it will come about. Thank you.
I think we'll have
My name is Ratan Sanjay. I represent Oracle Corporation, and we are a technology provider, as all of you know. So, fantastic insights into the digital health technologies, etc. My question is very simple. What are the key challenges that you see from a technology standpoint which will enable the growth of digital health? For example, I heard digital data acquisition being one of them. I heard data protection. What are those 2-3 points which you want technology providers like us to address to help you in building this whole digital health campaign? Maybe start with Gaurav.
Yeah. So we can take the last question and then we can address both the questions together. Yeah.
Am I audible now? Okay. Hi, my name is Chanansha. I am from Eka Health Private Limited. I just have one question. Isn't data privacy a myth? I book a consultation over one platform. My data is being sold to a laboratory next 2 days after, and then very prominently next 2 days after I am getting recommendation for the medication for the same. Isn't it a myth that we want to address?
So I think on the privacy part, I can respond being a lawyer in the sense that right now we don't have very.
So when are we expecting that?
We don't have tough laws. So I think once the bill becomes a law, there will be a lot of safeguards vis-a-vis that.
So
now,
till then, sorry.
So probably sometime this year, I think it's expected. Yeah.
Okay. So till then, we will have to, have suggestions from AI analytics being running, that I'm being suggested, a test by a laboratory itself, that since your parameters are fluctuating, you can undergo these tests, and then based on that, I'm getting a recommendation from another pharmacy. Right? That has to go on.
And that is why data privacy is so important.
Yes, that's what I'm talking about.
Let me ask you a question.
Please do that.
So what happened?
I think if we can address the second question relating to the technology.
Gaurav. Okay.
No, please go ahead.
Okay. Let me just, because this is just one question, very short one. So where were you putting all this information in?
Do I have to name the platform here?
No. Was it an email or was it some social media? No. I just want to know where did you put it in?
Of course, on a consultation platform.
On a consultation platform. Yeah, okay. Because what happens is that these people, when the data is being flown, all of these data. This is where the standards and everything else comes into play. See, if you use standards, you would code the data. And once you code the data, it is already pretty much secure.
Okay.
Okay, so it becomes that much more difficult to sort of farm the data and then sort of do whatever that they. The only other thing that I have to say about this data privacy aspect is that, yes, Dr. Gogia and others also touched upon this. See, till date, I have not found a single person saying, no, you may not share my data if my data can help somebody else become better. Okay, so the whole question about anonymization, that was just put it in. See, there are two things. Anonymization would be able to take it. Okay.
So I think you must have signed a privacy policy which gives that all rights as far as the sharing
Yes,
of
that's
data.
true. That's what I'm wondering. Even after signing that consent and everything, still, my data is being floating
So
in the
coming to your question, generally,
Actually, I don't know. Meaning, digital health growth is dependent and stymied by a lot of things. Largely, I think it's a demand. I don't know what technology can do. It's more of a market creation problem rather than.
Okay, I'll just, before you say it, because I used to work for Oracle, so I would have some insights into what you were asking for. No, you do not have anything more to offer. The rest is all the technical people are supposed to do it.
Yeah.
Okay, you have done already plenty. And because now the whole game is not on the database level, not on the interaction between databases. Okay, the main problem is now implementing it in a way so that the right products are offered to the right people. Like I was asked a question a few days ago as to who do you think is the consumer of your data, the data that we are talking about. Can anybody tell me? Who is the consumer of all this health data? Yes, insurance company is the first one but that's wrong. No, wrong. Anybody else has an insight? I'll give you the answer, no problem. Yes, it's the guys like Dr. Gogia and I. We are the doctors, we are the ones who are the consumers of the data. No one else is. So until unless we are satisfied that this is a product that we can use or we should be using, it will never happen. So you can build your, I don't know, are you aware of something called Oracle HTTP? Okay, so I used to work for Oracle HTTP 2004. Okay, so the point is this, that where is it today? The reason is this, because there was not sufficient demand generated by guys like us. And why? There is a lot of things that we will probably be here till for several hours while we answer that question, so let's not get into that.
No, I'll just finish off. Basically, again, and this was I was discussing with these people before that, we have to look at the change management side. There's enough technology. Implementation is the key, change management is the key. So as I said, I run SATHI, which is a Society for Intelligence, Healthcare and Informatics, which works on the 80%. Unless you have serviceable data which is usable, and we say anything which is not used is useless. So don't look at technology right now. Look at getting it adopted like he's rightly said.
That's what I'm saying. How can technology be an enabler?
So
Can only be if it is adoptable, it's usable. WhatsApp became usable.
So I think we are running out of time, and thanks a lot. Thank you very much for your valuable thought on the subject matter.
Thank you, panelists, and for such an insightful session. And we are just about to start the next session in 5 minutes.